Good morning, everyone. Good afternoon, good evening, wherever you may be joining us. We'll get started in just a few minutes. Okay, hello, everyone. It's a pleasure to have you join us today. My name is Pamela Collins. I'm a professor in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health and the director of the Center for Global Mental Health. We're happy that you are joining us today for our speaker series on Who is the Provider? And today we have Dr. Soumitra Patare, who is a psychiatrist and the director of the Center for Mental Health Law and Policy of the Indian Law Society in Pune, India. His primary interests are in the areas of mental health policy, scaling up mental health services, suicide prevention, and rights-based care and legislation. Soumitra has conceptualized and steered various innovative community-led health interventions and strongly believes that all persons with mental illnesses should be able to live and participate fully in society just as everyone else. So we're delighted to have him here, and I'm going to hand the microphone to you, Soumitra. Welcome.
Thanks, Pamela. Thank you. I will try and share my screen if this works. Hold on a second. Here we go. Okay. I hope this is working well. If not, then somebody just needs to tell me. That's all.
We'll let
Hi. So I was going to talk to you all about a particular program that we run in India called Atmiyata, and it's a community-based mental health program. The names you see below my name there are Dr. Kaustubh Zog, who's another psychiatrist, and Jasmine Kala, who is a anthropologist, sociologist, who currently co-lead the program. Although I started it, I do not actively co-lead the program, and Kaustubh and Jasmine co-lead this program. Atmiyata was recently listed by the World Health Organization as one of the 25 good practices in community outreach mental health services in the world. And so I thought maybe this is probably the one I should be talking to you about. Uh, First of all, why Atmiyata? That's the question. Why do you need a program like this? As you probably all know, mental health is a major public health concern in India. There is a huge mental health gap in rural areas. There are huge inequalities in accessing mental health care and treatment. A large number of people in India do not have access to mental health care and treatment. And psychosocial stressors play an important role in both the causation as well as recovery from any kind of mental health problem. Um, okay, if I can. Uh, let's talk a bit about inequalities and accessing. As you know, 8 out of 10 people do not have access to formal mental health care and treatment. There are a lot of informal services in India, including quasi-religious groups which provide services, but we are talking about formal mental health services. The rural mental health gap is a combination of both a demand problem as well as a supply problem. And the demand problem arises from things like stigma, discrimination faced by people with mental illness, and in the Indian context, a lot of structural social barriers, more particularly caste and gender. In terms of supply problems, I don't need to tell you about it. You all know this is common across the world. Some of the supply problems which actually impact people in India are poor quality of services, and secondly, high costs. Because India is a mixed healthcare system, private as well as public, and the private healthcare system is a significant chunk of the healthcare provision in India. So what exactly is Atmiyata? The word Atmiyata in Marathi as well as Gujarati, which is a neighboring state and the language there, really means shared compassion. It was a name that our communities actually chose for the program when we did a little bit of co-design work right at the beginning of the program. It is a community-led mental health and social care program. It builds upon social capital. So the idea is to use community social capital by working with community volunteers, and it's designed to be a sustainable, low cost, and a high impact model. These are some of the values of Atmiyata. Empathy is a very important value, shared compassion, as I said, and volunteerism and participation again. And as I said, this is a community volunteer driven program. It's not a lay health worker program. Uh, so in the WHO's way of looking at mental health services, where does this fit in? It's not primary, secondary, or tertiary care, and it's definitely not self-care. So it really does fit into this informal care section in it. So as you can see, Atmiyata is actually complementary to formal health services, and that's how it works in reality on the ground. So how does it work? The team has three broad people in that. One is champions, the other is a community facilitator and a project manager. Tell you very briefly about a champion. A champion is basically a village-based volunteer. So what we do is we usually go into a village, talk to the village council, identify somebody who is interested in working as a volunteer and has some leadership qualities. Over time, we've even kind of formalized a manual on how a champion should be selected, what are the qualities of the champion that we are looking for. And what do champions do? So there are four things that they do. The first and most important one is providing psychosocial support. So they are trained, supervised, and mentored to provide 4 to 6 sessions of counseling using three evidence-based techniques: active listening, problem solving, and behavior activation. The second that they do is that they can make referrals for people with severe mental illness. So people who have schizophrenia or bipolar disorder who might actually require medications, they will make referrals to the public mental health facility, which is usually at the district level. And frequently they accompany the person for the first visit, and they will ensure that the follow-ups happen and that people haven't dropped out of treatment. The third and most important thing, and which is different from other programs probably, is that they facilitate access to social benefits. As you know, poverty and mental health are very closely linked. And so, in some ways, addressing social care and ensuring people have some financial support is as important as providing them with counseling. So they help, they've been trained how to identify who might be eligible for what social benefit, and they help people actually access and receive those social benefits. And finally, they do sensitization of community members using, they have 4 films which are loaded onto their mobile phones, and they use what we call a narrowcasting model as opposed to a broadcasting model. So they'll kind of collect a group of 4 or 5 people, show them the films. The films are 10 minutes long. They're designed in a kind of Bollywood, which is very well known in India as the film industry style of a film, and it stops every few minutes so that the champion might ask a question, and there is some kind of conversation that happens between people. It not only increases awareness, but it becomes a way of identifying somebody in the village who might need help. And these films are really about what are precursors or what are other stressors, such as one of the films is on alcoholism in the family, another one is on unemployment, there's a third one on interpersonal violence, and a fourth one on family conflict. And that becomes a entry point on kind of linking social determinants with mental health issues, and also identifying, and somebody will say, oh, my neighbor, she's got this problem. Husband comes home drunk every day, and there's a lot of fights in the house. Maybe you want to talk to her. And that's how the champion would probably get some inkling of who might need help. The champions work about 6 to 8 hours every week. That's the amount of time that they would devote to this work. They've also been given thresholds at which they should make a referral. Okay, so there's a certain threshold. So, for example, if somebody's suicidal, they will make a referral to the district mental health team and then accompany that person to the district mental health team and ensure follow-up happens. But they will not then do any sessions with them till the district mental health team says they're fine, you can continue with your sessions, you can help with other things. Um, The champions, generally, this is the profile of what they do, and that's roughly what I told you about. They have basic literacy skills. They're not. We don't expect them to be educated highly, anywhere between 8 to 10 years of education, and we are happy to take them. That they should be willing to work as a volunteer, and they understand community culture and intricate relationships. The next person in the team is the community facilitator. Now, a community facilitator is a project staff. They are paid members of the team, and they do the following things. They identify mentors. They identify, train, mentor, and support champions. They liaise with local stakeholders such as the village council leaders and the village council. They will also regularly travel to the villages and sub-district headquarters to meet with staff as well as with the champions. And they have been given an app which allows them to monitor what is happening. So usually a facilitator will provide supervision and mentoring to anywhere between 40 to 50 champions, which means they're in a month they will cover 30 to 40 villages whom for these champions whom they are working with. And this is their profile. As I said, they tend to be mental health professionals of sorts, masters in social work, mostly with 2 to 3 years of field experience, and that they're willing to travel all the time. They tend to be locally based. We recruit them from the local area, from the local district, so they also understand the local language and they can speak the local language. The lady on the left here is an example of one of our community facilitators talking to one of the community champions. And finally, you have a project manager, and the project manager is again a paid member. We usually have about 3 to 4 project managers for a district of say 500 villages. And they recruit the community facilitators. They liaise and collaborate with government agencies. For example, they also conduct regular field-based visits for quality assurance, and they use the same app for documentation. This is their skill set, slightly more experienced than the project facilitators. In many instances, our facilitators have over time been promoted to a project manager. Um, these are some of our, this is just after training a photograph of some of our champions and project facilitators. The gentleman in the left, in from second from the left in white clothes, he used to be our project manager. Unfortunately, he passed away. Mr. Solanki passed away during COVID, which was really unfortunate for us. But otherwise, this is what happens. They usually have a quarterly meeting when they get trained as well as they get refreshers, and it's also a time to kind of encourage them for more work, a bit of a pat on the back, really. Uh, so Atmiyata has been evaluated. We've done a stepwise cluster randomized trial, which is published. I can give you the reference for it. And broadly, what did we find in this stepwise cluster randomized trial? Basically, people with common mental disorders at 3 months have a 2.3 times higher likelihood of improvement, and at 8 months, the improvement increases to roughly three times higher. What also happens is that in terms of functional and social improvement, you see that at 8 months. At 3 months, you largely see symptomatic improvement. Uh, what about champions' ability to identify people with common mental disorders? And what we found in the study is that they are about roughly 60% accurate. Now, when we say 60%, it's not that the remaining 40% are improperly identified, but what would happen is many of them are sub-threshold. And we encourage them to also work with people who might be sub-threshold on a scale like a PHQ-9. And so we don't say, oh, you can only take threshold people. Because the PHQ-9 was only used for the study purposes. Our champions don't use a PHQ-9. They've been taught how to identify somebody who needs assessment and help. The economic analysis that we did with the stepwise cluster randomized trial shows that Atmiyata is about $1 investment in the intervention gives about a $9.35 return in terms of improved health and productivity for individuals. In terms of reach and impact, so where are we currently? Atmiyata is being implemented in 14 states in India, 34 districts, and 5,000 plus villages, covering a population of about 4 to 5 million people. Uh, and the most exciting thing is that recently we got a grant uh, from Bart's charity, along with some of our colleagues from Queen Mary's University in London, and Atmiyata is now being adapted for and piloted for implementation in East London. So it's a good example of a reverse innovation, where a low cost scalable innovation which started off in the global south, moving to the global north. Um, Roughly in every district, we believe that our Atmiyata champions work with roughly around 25,000 people each year. 51% of the people who are helped tend to be women, and 71% of our beneficiaries are from marginalized castes, which means that we are able to reach the most unreached people. And these are our partners and funders, and I shall stop here. I don't want to go on too long, and maybe leave some time for discussion and questions. Thank you so much.
Thank you very much, Samitra. That was wonderful. Very exciting. I have lots of questions, and you and I will have a little bit of a discussion, and then we'll open it up to the group for comments. But please, if you're in the audience and you'd like to ask a question, feel free to use the Q&A button and feel free to use the chat. And we'll be monitoring the chat as well to make sure we capture some questions and maybe get a bit of a dialogue happening with all of you. So this is wonderful. You said a few things that are interesting. As we're thinking about who is the provider, what struck me is that you started out by talking about how this program builds on social capital, empathy, shared compassion. Can you talk a little bit about how those principles lead to the recruitment of the champions in particular, or who do you tend to see volunteering to be champions? Tell us a bit about the champions.
So it's very interesting. We get a range of people who are champions. About 25% of our champions are what are called ashas. The ashas are the lowest rung of the community health workers in India's public health system. They're not paid as salary. They're usually paid on a piecemeal basis by government. But many of them, about 1 out of 4 of our champions, tend to be ashas who volunteer to do this work, although we don't pay them. And They are mostly a mixture of either we get a lot of women, especially young women, who say that they would like to do work, but their families would not want them to work. So this is a good way for them to be able to get out and about in the village because they're doing some specific task. And we also get the other extreme end is a lot of women in their 40s and 50s who are probably in the Indian context in rural areas, they're already grandmothers. And this is a good way to then be able to give something back to the community. Many of our champions over time have also kind of graduated out of our program into either getting a full-time job somewhere, or have graduated and contested elections and become village council members and village council leaders. So it's a kind of what we look for is leadership abilities, empathy. We look for the ability to listen. And these are not things that there are some traits that we feel there are some things you can teach people, and there are some things that people need to have innately. And what we look for when we are recruiting is those innate bits, and the training and supervision bits. We feel we can give you the skills, but we can't really change those innate personality attributes, which might actually make you a very good champion. So that's how it is. And The question people ask us is, how long do these people work with us? How long do they stay? Now, this program's been running in for about 13 years in the very first district that we started off from. And usually our attrition rates are roughly about 20% a year. So every year we have to add 20% more because 20% will drop out. Most champions will work for 3, 4, 5 years. They might leave earlier if they've got another job. or because they've kind of decided they want to do something else. But that's generally the profile of these champions. I just wanted to highlight one more thing because I think it's important. This is not a task sharing program, okay? This is because they're not lay health workers and we don't train them and pay them as lay health workers. These are community volunteers. And the most important thing is that they not only look at mental health, but they also do social care, which is not what most task sharing programs do. They are not paid. So we believe that what happens is, in a sense, the community has ownership of the program. We've been telling our funders that for every $2 that you invest into the program for running this program, the community is investing $1 if we take into account the time that is contributed by these champions. So in a sense, the community is actually contributing to this program. They are not just passive recipients, but actually active owners of what is happening in their own communities.
Yeah, that's really interesting. I like that you explained that distinction between community volunteers and task shared providers. I think that's interesting to note. How does the village then decide to participate? What makes a village say, okay, yeah, we want to be a part of this?
So you usually will go up to a village. Initially, when we started off, we went to villages and met the village councils and said, "Oh, we have a program which could work for, a mental health program which can work for you." And then, the standard answer we got from a few villages was, "We have nobody's got mental illness out here. Everyone's completely fine. No mental illness in our village." And so we went back to the drawing board and said, "Okay, we're getting something wrong. We need to really do this differently." And so started going to villages and saying, "You know what? We've got a program to help people with stress and tension in their daily life." And then, village council reactions were, "Yeah, yes, everyone here is stressed. Everyone's got tension, too much of tension. Everyday life is tension." And we said, "Right, we've got a program which could help you for that. Would you like us to work with you on that?" And that's how it starts. And then we ask the village council to kind of identify people in their community and say, "Look, can you tell us 5 or 6 people who might be interested in this?" And then we'll go and talk to them. Usually, the villages that we cover are roughly about, have populations of roughly around 2,000, 3,000 people. That's usually what they are. They tend to, like in Mehsana district, which was the first district where we worked, it's got a rural population of about 1.5 million, spread across 500 villages. And in that district, we currently have about 700 champions. So, it varies. The larger villages have more than one, the smaller villages have maybe just one.
No, that's great. And the other question that comes to mind is when a village gets involved, how do attitudes change, right? If villages start out by saying, "Ah, we don't have any people that have those problems," as the program persists, do you see changes in willingness to talk about mental health conditions, willingness to talk about those? Yeah, what are you learning?
Absolutely. I mean, but we don't use the language of mental health.
Sure.
That's the most important thing. We,
Yeah.
we don't use the language of mental health anywhere. So the program is, over time people say, "Oh yeah, this is something to do with psychological issues and all," but it is not primarily sold as a mental health program. And people will usually refer someone, somebody in the village will refer to the champion and say, "Look, I have a neighbor who's having some difficulties. I think you can help them." And that's how they will. So they'll talk about the difficulties, but we don't make it into a mental illness definition. "Oh, I have got a neighbor who has a mental illness," is not how people will come up to us. And because we link the mental health issues with uh, social and structural issues, people will usually foreground that. They'll say, my neighbor, I think there's a lot of violence in her house. She gets beaten up. I've heard that occasionally. Why don't you talk to her?" So people will kind of use that as an entry point for wanting to. And interestingly, we recently had our champions telling us that we should actually add a component on gender-based violence and add an entire module to train them how to handle gender-based violence. What can they do? And they wanted more training on that. So we frequently get those kind of requests even from our champions.
So it's interesting because they then become known as people that can actually help you solve real life problems, right? Real life
Exactly.
problems that are actually that are causing stress, that are causing
Yeah.
distress as well.
Yeah.
That's wonderful. So it's amazing how much this has actually scaled already. Can you talk to us about this? I mean, this is the big conversation in global mental health. How do you scale and sustain programs? And this has been successful. So, talk to us a bit about scaling sustainability, who pays for this, and what can we learn from the process of scaling?
So at the moment, there are three different ways we are trying to scale up. One is obviously scaling up where we work in the districts themselves and we set up our own. So we deliver. The other is what we've got, what we call a franchising model. So we've been collaborating with a lot of NGOs, not profits, non-profits working in the health sector, and asking them to piggyback Atmiyata into their health program. So that increases our outreach, and they bring the funding for it, and they integrate it into their existing community health programs. And the third way that we are trying to scale it up is actually talking to government recently, and a couple of state governments have shown great interest in actually integrating this as part of their community mental health programs. One is a state in Northeast India, and another one in Gujarat. In fact, I have a meeting with them sometime next week where they want to say how can we scale this up across all 33 districts, because in the state of Gujarat, where we've been there for the longest time, we work in three districts, but there are 30 other districts where the government could scale it up. So that's the three ways of doing it. In terms of funding, for our three districts, we get funded by charitable charities basically fund us. Our cost is just roughly our cost per person helped is roughly $2. That's what it costs us. So a district will roughly cost us $50,000 to run for a year. And it'll end up helping 25,000 people. I'm giving you ballpark figures, not
Yeah,
exact figures,
sure.
but that's roughly how we would talk to funders when we are talking. People say how much it'll cost, and we say, look, a district roughly 50,000 US, $2 per person, 25,000 people helped.
So I think the other notable thing here is that you're very open to figuring out what pathways to scaling can work. You're not only focusing on government, I hear you're also looking to
No.
partner with NGOs, really looking at what's available in the environment, who could take this work forward.
Yeah, any which way it works, we'll try we just keep on pushing whichever one works. I mean, it's after 13 years that governments now want to scale it up.
Yeah.
Initially, we did the scaling ourselves. Then we got other health NGOs interested in it, so we scaled it up through them. And now we're getting government saying, "Hey, we could help you scale it up too." So I think you have to just be very flexible. If you see an opportunity somewhere, you take it. That's it.
Super exciting. So began to talk about taking this work to East London. Um,
Yes.
and that's something we're all excited about this broad global conversation around mental health because we can learn from each other. And this kind of example of figuring out what's happening somewhere else that may be effective for the population wherever you happen to reside. This idea of how do we translate and how do we successfully do that is something that's, I think, one of the real resources of this field. So talk to us a little bit about the work in East London. What are you learning about adaptation needs? Yeah, how's that happening?
So, first, I mean, how did East London happen was Tessa Roberts, who's a lecturer at Queen Mary's University of London. She's visited our project before, and she's always been interested in. And then we applied for this grant, and Bart's charity were very keen on it, so we got funding for it. So the adaptation. Fundamentally, the adaptation requires us to think local in many ways. But what we've realized, we've now at a point where we are starting a pre-pilot next month, which means the champions are going to get trained and they will be asked to go. A few champions are going to get trained and then be asked to go out and actually try and do the work. What we found is that the adaptation is really about getting local context. But fundamentally, the things that affect people, the kind of things that create mental distress seems to be global. It's common. So there are some things which are very common, which is what makes somebody feel distressed, mentally distressed in any community, especially if you are living in deprived communities. Uh, but the context on how it is experienced, expressed, and supported would be very different. Um, UK also has a very good network of general practitioners. So then instead of relying on the district mental health teams, what we said was, oh, we'll use the general practitioners who are reasonably well trained in mental health and were happy to work on the mental health issues. So the referrals go to the general practitioners rather than going to the district mental health team. It's just one example of how you try and make adaptations to even your structure depending on what is available locally and what is really working locally.
Very interesting. That's great. It'll be interesting to see how that proceeds. So we'll look for those papers and we'll look to learn from you around that.
Yes. Yes,
So there
we're
are lots
really
of
looking
questions.
forward to that.
Again,
Really
yeah,
looking forward to that
no,
one.
I can imagine. So there are lots of questions pouring in. So I'm going to just ask you to go back to the very beginning. How did the idea of Atmiyata come about? How did that even start?
As with all things, this was in 2011, and I'd been working in community mental health for a while and getting extremely frustrated with the focus on health, mental health as being the focus, and this whole idea of vertical things. And I felt that I also felt that we need to stop looking at our communities as just passive recipients of care, but to start actually actively engaging our communities in becoming providers too, not just recipients, but also providers. And in India, and I'm sure in other countries too, there's a lot of social capital that we don't tap into. And so that's how the idea of Atmiyata started off. We got a small grant, I think in 2011 from Grand Challenges Canada, where we tried it out in 40 villages, just testing out how it works, what doesn't work. And that kind of over time then built into a larger program. But it was largely a certain amount of dissatisfaction for me uh, on seeing mental health as a purely health issue and in isolation of people's context and people's structural and social problems. I think we need to very well embed mental health into those structural and social issues and need to address them both. It's having worked in clinics where you get a woman who comes in and you say, "Oh, you're depressed, here is a prescription, come and see the therapist." And she's experiencing interpersonal violence at home. She's got a husband who comes in drunk every day and beats her up. And I'm sure she's thinking, how is this going to stop my husband beating me up? And why would taking a pill and coming and talking to your counselor make any difference?
Mhm.
And so very often, I think what we offer as interventions and treatments make no sense to our population. We what we do, for example, is we don't have a clinic in these villages. We don't have like a center or something where people come to. Our champions will meet people in their daily context and daily work. Like a couple of examples where a therapy session might happen, for example, is like if a woman's gone off to the river and she's gone there to get water or she's gone there to wash her clothes, and that's the place where she's likely to be alone and she thinks she'll get all the privacy that she needs. Our champion will go there and sit with her and do the therapy session. And we don't say, oh, it has to be 45 minutes. It can be a 20-minute session. It can be a 30-minute session. It doesn't have to be that long, or go home if required. Or sometimes mothers are waiting to pick up their kids from a school when the school is going to be, when the school ends, say at 3 o'clock. And the champion will go and sit with the mother while she's waiting and do a session out there. It becomes embedded into day-to-day life. It's not something for which you need to go to a center or a clinic where you'll, oh, I go there and sit across a chair and table, and now I'm going to get therapy. So we don't even call it therapy. We just say, look, this is about somebody talking to you to help you with your difficulties.
Yeah, that flexibility sounds incredibly important to help this. It's very naturalistic in that sense.
Yeah.
So here's another question. Can you speak to the culture of volunteerism in this area? Talk about how this
Well,
actually
I mean,
leads.
I've had a lot of people say, "Oh, this will only work where you work or in India because there are lots of people who will volunteer. You go to other places, there is no volunteerism." But I don't think that's true. When we first started off in India, we were told by everybody, "Oh, nobody will volunteer. People expect to be paid." Um, And it's not true. I mean, people volunteer. In fact, what happened was, in between, our funders got after us, and even our ethics committee had got after us at one stage, saying, "Oh, we are not paying them. This is unpaid labor. What's going on? Why don't you actually start paying them? You should be paying them a token or something of that sort." And so we had a conversation with all our champions. We actually went and met our champions and said, "Look, this is what we are being told." And interestingly, a large majority, if not everybody, but a large majority said, "No, you shouldn't pay us." And the reasons were very interesting. One young woman said, "Well, if you paid me and said this is a job, my family will say, 'Quit the job. We don't need the money.'" Uh, and then another person said, "Well, if you started paying people, I would never get this. I would never get recruited into this position, because the village head and the village council members would ensure that their wives and daughters were onto it, and they would get paid, and they would probably do no work. So I don't think you should be paying, and this is not stuff for which I'm spending that much time. I'm probably spending an hour a day or so on an average." And so we went back to our ethics committee and said, "Look, these are the findings. Our people are saying that we shouldn't be actually paying for it." And they didn't see it as work. That was the other thing. Many of them saw it as giving back to their communities. Giving something back to their communities is also, funnily enough, or at least a fourth, I would say, a fourth or a third of our champions have said, "One of the motivations for me to work is because I have had suffered this kind of episode of depression." They didn't know the word depression, but when we would train them, they would say at the end of training, "I have suffered this in the past and I didn't get any help. So I want to ensure that other people who are in this position or in this situation get the help that they need." So, there is a lot of that in our communities. And what they need is hand holding and mentoring. See, we don't just train them and say, "Right, you're on your own, go off and do what you like." We don't do that. They get structured supervision once, twice a month in a group setting. We also do a lot of in kind of stuff with them. Okay. So, for example, one of the things that we do is that all of our champions get a mobile phone, and the mobile phone has a bright yellow back cover. The yellow thing has become like a thing where they'll wave it, saying, "I'm a champion," kind of a thing. Even when they go to the hospital because they're accompanying someone, they'll go and say, "I'm a champion," and wave their yellow phones in hand. For women, it also meant that they had a pretty fancy smartphone, which maybe their husbands didn't have, and so they held on to it. Where it became an identity thing. Uh,
Mhm.
After training, they wanted certificates. And when we first gave certificates, the first thing we were told was, "Well, can you make the certificate a bit bigger and a bit more grandiose?" And if you go and visit our champions' home, the certificate is framed and put in a very prominent place in the house. They regard that as something that they've achieved. They've done something for their communities. And once a quarter, we actually have a meeting where we bring all of them together. We kind of, it's a day when you can share stories, enjoy, have a great meal, and people give out some awards for Champion of the Month and that kind of stuff. And it's also a way of building a community of champions. So there's a lot of laughter and fun and games, and we try and get some senior government functionary to come and maybe speak to them, like, give a talk for 15-20 minutes, half an hour, and encourage them to continue. So they do get a lot of in kind of stuff, although they're not getting paid in cash. Um, that's probably how it is.
That's great. So they're clearly recognized, they're valued by this community, and they value this role.
Absolutely.
That's clear from what
Yeah,
you're
yeah, yeah,
describing.
yeah.
So
Yeah.
lots of questions are pouring in.
Sure.
Um, do you have a sense that community volunteers use their skills in other ways outside of the programs with their families? Has the expansion of the program changed norms and stigma around mental health? You've talked a little bit about that, but yeah, how do people use these skills more broadly?
Oh, they use it in many contexts. They use it, in fact, for example, the request for saying, "Can you help us work on the issue of domestic violence or gender interpersonal violence," is because they started getting requests from, other people in the village saying, "Hey, you know what? You need to go and help that woman. There's a lot of violence in the house." And then the champions coming back and saying, "Listen, you've never trained us how to handle that. We know how to deal with the mental health part of it, but what do we do if there's violence? Are there resources we can use? Is there something we should be doing? Whom should we be talking to? How do we talk to them?" So, over time, they start getting seen as someone who knows everything. So in fact, what we've heard from champions is people go to them even for general health problems. Somebody's got a health problem, they'll say, "Oh, go to the champion." They'll know what to do about it. Um, when they go to the local district hospital, for example, everyone in the district hospital knows them. So if they're going to the district hospital to attend a mental health OPD, they will almost bulldoze their way through and say, "Listen, I'm here, I'm a champion, I'm here with this person, needs to be seen," and all. So they do tend to, get known even in their local surroundings. So yeah, they do that. And like I said, some of them have then gone off and contested elections. Others have gone off and taken a full-time job somewhere because they learned, they just developed a certain skill set and confidence to do things.
Great, great. So we have a comment from a participant named Stuti who works for a foundation in Gujarat who's planning to start a neurodevelopmental disorders program to identify and manage people in the pediatric population, especially in the rural and tribal areas. Studi loves the idea of champions, and it's something that they would like to adopt for their program. Studi is wondering how training works in this situation, since the base knowledge will be at different levels for different people. And also, this idea of Bollywood style awareness videos is pretty interesting. And can we see an example? But anyway, Studi would like to get in touch with you and learn more.
Sure.
Can you talk about this different levels of training needs that people may have when they start to be
So
champions?
look, we're very clear. We don't assume that people have any knowledge at all. So we don't start off with a certain presumption that people have a certain knowledge. The other thing we've learned from training is that we don't try to do training like a 5-day training program. Most of the people whom we work with are people who are rural folk, and some of them might be working as agricultural. They might have their own farm. They're working in a field. They're not used to sitting in a classroom. They're also not used to listening to lectures. They don't get it. So we had to do that right at the beginning, where almost all of our training is done through role plays. You know what? If you remember animation-based training, that's what we call it. Okay, so all the training is animated and it's done in an animation style. Secondly, we don't do 5 days we do half a day at a time. And so the training for the champions when they are first selected will spread itself out over a month or a month and a half. Because you can't expect them to sit for 5 days or even for a whole day. They just won't do it. And also this, you do half a day and call them back next week for another half a day, and then you can go over what has been done. You give them a little bit of homework to do when they're home, and it goes at a slower pace than what would normally be done, where you bring people into a classroom for 5 days and try to train them. So you do that, and we do regular refreshers every 3 months. They'll get a half a day of a refresher at least, because
Okay.
we know that you're not going to remember things otherwise. The other thing that we've realized is that when they finish training, they are very anxious to actually start. The biggest challenge is getting the champion to take up their first client, so as to speak, because they're really anxious. And that's where the facilitator comes in. The facilitator will handhold them, say, "Listen, come with me. You just sit and observe with me. I'll do the first person with you." So the first client you take, I will do everything. I'll talk you, I'll handhold you. And the second one you do, I'll sit with you and I'll tell you after every session if something went right or something didn't go right. And once you feel comfortable, then I'll stop doing that. So usually they take 2 or 3 clients, and then they say, "Okay, I think I'm now comfortable. I can do it on my own." So you have to do a lot of that hand holding to get people started. You can't just say, "Oh, you're trained now. Why don't you go out and do it?" People are extremely anxious about causing harm. The other thing that we cover in the training, and it's a significant part of the training, is the whole issue around confidentiality. Because you see, they come from the same community. These are small communities, and so there's a lot of work that goes into understanding and maintaining confidentiality, and to not accidentally start saying things to people which could actually breach their confidentiality. In fact, during COVID, one of the greatest things was, when we had lockdowns, all of the villages in the districts where we work had a counselor in the village who was available, who went and saw them home if the people were distressed, and who then received their supervision from their facilitators down a phone. We were using WhatsApp to kind of make those phone calls with the facilitators because they couldn't travel. So we've used technology. I don't think we are Luddites about technology, but I think technology is sometimes overrated. I think you should use technology when it's necessary and when it's useful, but not make a fetish about saying everything has to be technology driven. I mean, we use technology when we can, and in many ways, I mean, people don't see this that way, but a training manual that we have is also technology. It may not be digital technology, but it is technology. It has a lot of skills that are built into it. But the emphasis in training is on getting people to build their skills. So
Mhm.
it is not about trying to teach them what is depression and how does depression get better. What it tries to teach them is active listening, how to do active listening, and practice your skills on active listening, or problem solving. How do you go about doing problem solving? What are the steps? Behavior activation, the same thing. So these are things you actually teach them in terms of skills, and not focus on education. At the end of it, they might not actually know. In fact, they don't even use the term depression, anxiety, and all of that. They'll say this person has problems. But in a sense, we've actually taught them in their own heads to go through a PHQ-9, if you know what I mean, without actually holding a PHQ-9 in front of them. Uh, and that appears much more natural rather than to give them a checklist and a questionnaire and say, oh, can you please fill up this and tick boxes on this? We just don't do that because most people say they don't like doing that. And you start ticking boxes, it doesn't work that way.
Okay, lots more questions. So you mentioned before that villages are about, maybe you're talking villages of about 2,000 people. Is there one champion per village, or that came up? How many champions are there in a village? How is the labor of providing the support spread out? Someone mentioned that ashas themselves are often overworked.
Yeah.
So how do
Yeah.
you protect your champions, and what's the distribution of labor like for them?
So initially we started off with this idea that we should have one champion for roughly 1,000 people. Okay. Um, that over time hasn't really worked out as 1,000 because there are sometimes villages which are like 500,
Mhm.
and you still may have a champion. And then there are villages which might be 2,000, and you think, oh, one champion is good enough. And then there might be villages which are 3,000 and need two champions because there's more work to be done. So a lot of that is, like a rule of the thumb has always been a champion for 1,000 people. Which is the ratio we've always had in mind, but it doesn't, like, for example, the 500 villages that we work in Mehsana has about 700 to 750 champions. And the number varies. Some people drop in and some people join in. And so, you also have to keep on recruiting and running your training program quite repeatedly. It's not something that you did one off and that's the end of it. Um, that's how it works. And ashas, I mean, we don't go and look for ashas. It's the ashas who actually come and volunteer, and we frequently say to them, listen, you're already, this is not like an asha program. You're not going to get paid. We don't pay people. And they say, no, no, that's completely fine. I like doing this work. I want to do this work. And they come in and choose to work on that program.
So that's interesting. So that to me means that people that already have some of these skills, they're drawn to this because they
Yeah.
chose to be ashas, and then probably want to use their skills and refine them in other ways as well. So a question is about, who do you support? Are the clients primarily women? Do you also support young people, adolescents? Are there different approaches depending on who is the person seeking help or support?
Broadly, what we would do is that we will support adults. Okay,
Okay.
we don't think we build the skills of our champions to be able to support adolescents and children. What they do though is they'll provide support to the parents, for example, and they will ensure that the person does get referred to a district mental health service where there might be professional help available for adolescents and children. It's something that we've repeatedly thought, should we expand the scope of work? But it's a fine balance between wanting to do more and then overburdening your champions, uh,
Yes.
and
Yeah.
uh, and then deciding what you want to do. So we've taken the approach that we will, whatever expansions or additions we'll do will depend on what our champions are telling us they want to do. So like for example, violence in the family, domestic violence is something that they want us to actually work on. So we said, fine, we'll add that module and we'll train you on that, because that was bottom-up requests that came from them. So that's how we've taken, but largely we'll try and address the what I call the 20 to 40-year-olds, or 20 to 50-year-olds, the adults who.
Okay. Okay, no, that's helpful. So a question has come up about this, that, these are folks who are exposed to people experiencing gender-based violence, for example. And the question is, what kind of safety training do the champions receive? And one question in particular is that when there are certain groups within a community that might experience more violence, like queer individuals, how do champions learn and what is the safety what is their safety approach to help people find safe spaces or what have you?
I won't be able to give you specific examples of specific instances, but I'll give you a broad answer. First of all, personal safety and generally safety of the participants is something that they are taught during their training. So, if you know something is happening, should you go to the woman's house, for example, not go to the woman's house? Where can you meet her? And because they are from the local community and they know the intricacies in the community, frequently they pick up things that we probably as outsiders wouldn't even pick up. So they're pretty good at identifying that. Secondly, the village council and the village leaders, so as to say, or the village elders know the champion because they've been selected in collaboration with them, and we tell them that, listen, these are the champions, or this is the champion in your village. So they know they can always go to the village head for help if they are feeling unsafe or if there is an issue about somebody's safety. So they can access help that way. The third is that they can call up, they have access to the facilitator. They can call up the facilitator anytime in terms of safety and get advice what should they be doing. So in fact, we encourage them to do that. They anyway get regular mentoring every 15 days. But in between, they can also call up if they have some safety concerns, either about a participant or about themselves. And they can call up because they have a phone and they can call up and they can speak to. So those are broadly the kind of safety related issues. We've really not had in 13 years, we've had one or two instances with our facilitators, but those were more like they got hit by a bike while walking on the road or something, which is not really anything to do with the work they do as much as, and then we had to put a whole thing in saying, okay, should you be taking your bikes or not taking your bikes and all of that stuff.
Okay. No, that's good. That's helpful. Um, I saw a comment go by from Ken Thompson, who joined us not on the webinar series, but in person to talk about integrative ICT community therapy. And it's just making a comment that there are some interesting commonalities across these community-based approaches to support, and that it would be interesting to see what we can learn across these different approaches. So we can
Yeah.
stick a pin in that and maybe actually have a conversation in the future that brings several people together thinking about these different approaches.
Absolutely. I think also we should not try to have this. I think health generally has this bad habit of saying, oh, here's one model everyone should adopt. I think we should have multiple models and see how these models work, because different models might be suited for different geographies or for different population groups, and the same model will not work across all geographies and all population groups. And in fact, we should have a diversity of models. We should not just say there's just one model. Let's use this model. Everybody use this model. I think we should really allow models to develop bottom up. And that WHO thing that I referred to, people should look it up. It has 25 case stories of different models from across the world, all of which are trying to do the same thing, which is community mental health, but doing it in different contexts, in different geographies, for different target groups and all of that. So I think we should actually look at that as a range of, a menu of choices really of what you could have, rather than to say one size fits all.
Yeah, absolutely. I think that the diversity of options, and also it's nice to see what actually is shaped, right, by a particular context, right? What are you learning in this
Yeah.
context that's useful? We can all learn from that, but it doesn't mean that you're going to have a cookie cutter approach to the same
Yeah.
issues.
Yeah.
All right. Well, we are approaching amazingly the end of our hour, and I want to thank you again, Soumitra, for a really stimulating conversation. This is great and amazing work, really amazing work. And like I said, we look forward to seeing what you learn as you continue to scale in India, but also what you learn from East London. That'll be quite valuable for all of us. I want to take a minute to thank everyone for joining us, and we will continue next month with another session. On May 13th, Dr. Cyrus Mugo from the Kenyatta National Hospital in Kenya will join us to talk about his work, Filling the Gap, co-designing, testing, and integrating task-shifted mental health services for adolescents and youth in Kenya. So watch for the announcements, watch for the registration for that presentation. And again, want to say thank you again to Soumitra. Join me in thanking him. And we'll see you all next time.
Thank you. Thanks, Pamela. Bye bye.
Yeah, thank you. Good to see you.